has been a good year for FFR data. A lot of trials came which were negative, starting with the ischemia trial, future trial, Ripcord trial. Most of them were not in favor of this physiology-guided intervention. But before that, we have enough data to say from data coming from FAME 1, FAME 2. Definitely, angiographic guided intervention, when you compare with the physiology guided intervention, definitely the outcomes are better if you do angioplasty by on the basis of physiology guided intervention. So here I have a patient who underwent cardiac evaluation. He is a 68 years old male, diabetes, hypertensive. He presented to a local hospital with a history of effect angina. He underwent stress test at that hospital, and it showed positive in the late stages, and he was advised angiogram. So on the basis of that, patient was taken up for angiogram, and his LV functions is normal. So here is a patient with a stable heart disease, diabetes with a background history of significant history of diabetes mellitus, treadmill positive, coronary angiogram. This is the treadmill you can see, 1.5 millimeter. If you go by the ischemia trial, to say moderate or more than moderate means it should be at least 1.5 millimeter in more than 2 leads. Here it is there. So it belongs to a moderate, at least moderate category ischemia. So this is a angiogram. You can see he's having a very high grade stenosis in the distal part of the circumflex artery. And if you see the left anterior descending artery, after the septal branch, you can see a moderate to severe stenosis in the LAD. And this is a right coronary artery which shows similarly a high-grade, moderate to high-grade stenosis in the mid-RCA. And there is also a long lesion which is in the distal part of the right coronary artery. So patient was offered bypass surgery by that physician, but patient was very hesitant to undergo a surgical procedure, so came to us. We thought after looking into the clinical history and the background of treadmill test, which was positive in the late stages, we thought, why not do a physiology-guided intervention in this patient? So we did FFR to all the 3 vessels. Intravenous adenosine was used. You can see, start with the right coronary artery. You can see it is negative, even though the patient has a 2 lesions, one in the mid RCA and another one in the lungs, another one in the distal RCA were negative. And you can see that even the LAD, even though it looks somewhat moderate to severe in the proximal segment, it's turned out to be a negative in this patient. And even the circumflex, even though it appears very tight in this, but since it is a very distal and the amount of myocardium supplied by this branch is very small, it came out to be surprisingly negative also. So patient was put on optimal medical management. This was almost 3 years back. He's coming for regular follow-up and still is doing very well. So the aim of presenting this case is still the best treatment in a stable heart disease is highly debatable. As per the ischemia trial, you can see even the physiological intervention is not superior to medical management. Even if you do a physiological intervention, it is not superior to medical management. And even though the data from FAME 1 and FAME 2 is favorable for physiological intervention, and the last year, as I said earlier, it's not been good for guided intervention. But we can't take this result as a directly, but there are certain benefit also as per the, there are certain group of patients, subsets in the ischemia group, where if you have a quality of life, that is very, very important. If a patient is a young fellow, highly active person, and he has significant angina, definitely it is improved by revascularization, early revascularization, that you should keep in your mind. And if patient has LV dysfunction and heart failure, definitely he gets major benefit by doing a revascularization rather than putting him on the medical management. So with this, I conclude that FFR is not only important in identifying a culprit lesion and doing angioplasty, it also helps to identify lesions which are not hemodynamically significant, because putting a stent in this vessel always carries a risk in the future. So we have to go by the data accordingly. Thank you.